patient comfort, accessibility, and workflow efficiency. My name is Jay Anders, and I lead GE Healthcare's CT business for the United States and Canada. Our speaker, Sarabjit Singh, has an impressive background that uniquely qualifies him to speak on this topic. He is currently the Director of CT Research at the University of Washington, where he and his team have been at the forefront of implementing and refining these advanced imaging techniques. With numerous publications and extensive hands-on experience, Sarabjit brings a wealth of knowledge and practical insights on this topic. Today, Sarabjit will be shedding light on how he leverages GE Healthcare's technology to perform non-ECG-gated coronary CTA exams. He will speak to how this technology is helping to transform patient care, the specific scenarios where these exams are particularly beneficial, and the future implications for both patients and healthcare providers. Please join me in giving a warm welcome to Sarabjit as he presents on how ECG-free coronary CTA scans have allowed for more streamlined diagnostic exams, both operationally and clinically, and has allowed for the University of Washington to unlock even more for their patients. Sarabjit?
Thank you, Jay. Good afternoon, everyone. I'll start off with this slide, and I'll give you a few moments to digest your lunch and reflect back at your cardiac imaging journey so far. This takes me back to my days at MGH. I started in 2007, where I was super excited about the snapshot pulse technology. I don't know how many of you remember that, but my mentors like Sunny Ibarra back at MGH used to call, these were the Ferraris in CT world at that time. And it's very important to know how to use those Ferraris and at what pace can you write those scanners. So this is just a timeline just to show you how far we have come in cardiac imaging. We could achieve like 70-80% dose reduction back in 2007. And my pointer is right there, yeah. And so finally we moved on to a 750 HD scanner, which is the high resolution ultra-low dose cardiac scanners. We remember the snapshot freeze where we could intelligently correct the motion. That was your first technology in cardiac CT. We moved on to a Revolution CT with a one-beat cardiac scanner. In 2016, we had a smart phase. I don't know how many of you remember actually trying to figure out what's the right phase, but then we had a smart phase technology to exactly figure out what's the least motion in the cardiac cycle. We moved on to deep learning image reconstruction. A lot of work was done on iterative reconstruction and now deep learning IR in 2018. And slowly we developed these technologies. So like we have a SSF, which is a snapshot freeze, and now we have snapshot freeze 2 technology. Finally, we're moving on to a cardiac scanners, which can rotate at 0.23 seconds. Think about it, it's a great technology. We're almost reaching that levels of centrifugal force limit and all that. And now finally, I'm excited to present a new innovative technology where we're trying to say, can we do an EKG-less cardiac? And think about how much operationally it's going to help us. So this is just a journey of the cardiac CT for the past 10, 15 years. My short career in cardiology, I'm assuming you have a longer experience in cardiology. But think about all the technology which has brought us to this stage, especially snapshot pulse, snapshot freeze, your motion corrections, and your smart phase for the automatic selection of your phase. Here's an example of your diverse patient group which you see. And so Apex Elite Scanner can currently give you a consistent image quality with a one-beat cardiac acquisition in every cardiac patient and in any challenging scenario which you can think of. So you think about if you want to chase a low-dose CT. I remember back in those days where we were like double-digit millisieverts, 10, 20, and now we can do a less than 1 millisievert cardiac CTs. So here's an example of 0.6 millisievert. You can think about your high BMI patients, typical challenges with photon starvation, all the image noise. And I remember building protocols around different BMIs, different body weights. Should we look into, the body weight or BMI or anything else. But we have evolved all our protocols, and now we can get this consistent image quality with these scanners. We can get into high heart rate, like here's an example of 140 beats per minute. Pretty impressive image quality for that. You can get into scenarios of atrial fibrillation, any of your variable heartbeat. And you can see like you have a consistent image quality in all these challenging scenarios. But what's the common theme over here? If you look at the bottom of the screen, all of these cases have an EKG signal over there. So we leverage that signal to get us the least motion correction, like get the cardiac phase which has the least cardiac motion, recon our images and get the best image quality. So it's a kind of a merger of a great technology and clinical needs that we are able to deliver consistent image quality in any kind of challenging situations. Now, what if I don't have a EKG signal? And everything was dependent upon my EKG signal. And now you would ask me, like, under what condition I would see these scenarios that I don't have a EKG signal. It could be any of these challenging situations in a busy workflow. You can have highly instrumented patients where you don't want to attach any other monitor or you don't have enough space. It's a very busy workspace with people, with equipment. You could be in an ED setting, in a trauma setting. You want a fast cardiac evaluation. You don't even have a few seconds to wait. Or any other circumstances which is basically preventing you to get an EKG signal. I think globally, it reminds me of med school days back in India where I used to wait for an EKG tech to come in and put in all the leads and such. So it could be any of those scenarios, and you think about globally that how can the EKG signal be impacted. And also we can think about other potential protocols like TAVR, planning, follow-up, portal vein elevation. So basically, any of the situation where you're thinking like, how is my EKG signal delivered to me, and is there going to affect my workflow? So these are the situations where you can leverage an EKG-less cardiac CT. Now, moving from a little bit of challenging situations to a routine clinical, think about all the steps which your CT tech has to go through to get the EKG signal. We have to prep our skin. We have to attach the EKG patches, make sure your patches are new, make sure they are radiolucent, silver chloride, and all those kind of things. Do I have my grounding strap? Do I have anything else attached? Patient identifiers and things like that. Do I have my impedance check? And basically, ensuring that your EKG trace signal is displayed on your operator console. So all these things add time. It adds steps for your CT tech to get through things done. And you make sure that any of your cables are not tangled enough. Your table is moving fast. Now you're doing hyperdrive, fast table movements, and make sure any of your cables is not interrupting your EKG signals. So to get the EKG's less cardiac CT and unlock the potential of cardiac scanning without the EKG trace, you need basically 4 of these technologies. So it's a mix of hardware and software. You definitely need your wider detector, 160 mm detector configuration. And this will be used for your single beat, full organ coverage. You need your ultra-fast gantry speeds, 0.23 seconds per rotation and 0.2 seconds per rotation. The other technologies I was mentioning earlier was your smart phase, which is your automated phase selection for your least cardiac motion. You do need your snapshot freeze too, for basically correcting any of your heart motion. And this technology is currently only available on your Revolution Apex, Apex Elite, or any of your Revolution CTs with Apex Edition products. So keeping that in mind, you have your hardware and a combination of your softwares. Once you have these checks, you can basically acquire EKG-less cardiac data. Now, probably most of you are aware of the smart phase technology, but just a brief snapshot of what it is. It's basically selecting your right least cardiac motion phase for you and giving you a good image quality. So if you compare your left to the right, you can see your image noise is less. You can probably see your coronary vessels more well delineated with the smart phase. You even have less sort of streak artifacts on your right side. So it's a technology to help you to figure out the best phase for the cardiac motion. And in case you have cardiac motion in your coronaries, you have another technology to help you, which is the snapshot freeze 2. So essentially, there are several published studies on snapshot freeze 1 and 2. So 2 is basically now you can go into the three-dimensional motion. 1 was you can have X, Y, and now you can do non-coronary intracardiac structures and other stuff. So basically now we are able to simplify any of your motion correction, which is going to happen in patients where you have high heart rate or arrhythmias and things like that. And again, it's well shown that your image quality is improved, your diagnostic acceptability is better with these technologies. And these are sort of the prerequisites for your EKG-less cardiac. Now here's a slide. I deliberately made it very cluttered on your left side. You can see these are all the steps we have to do to get our EKG data before, and once you have your EKG-less, that's afterward. So let's look at the before steps and think about from a CT technologist and a CT operational workflow point of view, where anything which we have to acquire, we have to make sure all of these are sort of met. And this is sort of the recommendation. So your CT technology team is reading about it. Your supervisor are making sure all of these are acquired. So, to get the signal, make sure you have, you don't place your electrodes on your muscles, so you don't have too much activity. You don't place it on your scars, so it's a thick tissue. You might lose some signal. Make sure you shave your skin at least 4 inch. You remove any of your lotions, oils. Gently scrub the skin, make it healthy pink. I'm thinking as a CT tech, all these instructions are given to me to make sure that I get a good cardiac signal. Right? Don't use any of your alcohol for your prep sites. Place your leads. Keep the leads away from the scan field of view. Always use a new EKG electrode, which should be radiolucent, silver or silver chloride, with a fresh gel pad, so make sure you trash the one which has been used. And now think about your CT workflow over there, where your team is constantly working to make sure they check all these boxes. And once you have your electrode placed, you want to make sure your monitors are connected or not. You turn on your monitor, configure your connections is all set between your gantry, monitor, console. Check for impedance. All your 3 or 4 electrode has been green. That is, it's less than 550K ohms, or is it red? Replace it, test it again. And finally, the more important thing is, as your tables are moving faster with cables and everything lying around, make sure any of your cables are not tangled into the table. Right? So all these things are adding to your time, to your inventory. Your team, your cardiac team is already thinking about what kind of leads do I make sure I have. So this is adding to the inefficiency during the cardiac exam. On the other hand, you have this CT table, you have red going into red and green going into green. That's pretty much it. You have one click on your software configuration where you tell your scanner that, hey, I have something internal cardiac monitor versus external. So the steps have been cut down. It have been simplified. Thinking from a CT tech point of view, CT operations point of view, how can we simplify the EKG signal and how do we acquire that signal? So in the end, how it's done is basically you get an estimated beats per minute or your heart rate. You select your acquisition protocol. Make sure you have your smart phase turned on to figure out your right phase of the cardiac cycle, least motion. You have your snapshot freeze 2, which is going to correct your motion artifacts, if there are any. And once you have all these 4 checks, you move on to the next one, is you don't have auto gating, so there's no heart rate recording during the breath hold, but you manually enter your heart rate on a GE scanner interface. And to obtain a heart rate, you can use any of these FDA-approved methods, which is either a pulse oximeter, you can use a blood pressure cuff, you can even do any of your radial, carotid, pedal, brachial artery pulses with a healthcare professional. I remember my days back in med school, I used to do this. I didn't have an iWatch, and I used to look at my watch and actually record the heart rate of a patient like this. The scanner does accept a range of 30 to 200. I hope you don't reach any of those, but mostly we are in like 60 to 80s range so far. And heart rate can change during your scan acquisition. So do record a couple of readings around your heart rate, and you can kind of put the most appropriate one for this study. And so this is how the interface looks like right now. So if you select your scan type as cardiac, the mode will be given to you as EKG-less cardiac. You still have your options of your cardiac axial, cardiac helical as usual. The only thing is this is sort of an add-on as a EKG-less cardiac axial mode. You select your rotation time. Before that, you actually have to manually enter your heart rate, your beats per minute, which you just estimated. You put in your rotation time, 0.23 or 0.28. You look at your detector coverage, and I will recommend that whatever your routine is right now, whether you're using 16 centimeter, 14 or 120 mm, you use that as is. The auto gating is turned off, and you only pick the part 1 for the acquisition window where you put in your, basically the fraction of your beat which you would be using. We started with the full cycle, but you can have option of 3/4, half, 1/4 minimum of your acquisition window. Here's the recommendation for your heart cycle phase. So you can use a full window if you're looking for a left ventricle analysis, wall motion, any of your valve function, any of your coronary assessments. You can use 3/4 if you're looking for a lower dose option, especially for coronary assessments only, and if it's an intermediate heart rate, we defined as less than 80 beats per minute. You can further decrease your acquisition to half beat cycle if you're looking at a lower dose option and you know that patient has a lower heart rate, so less than 55 beats per minute. And it could be a potential choice for your non-contrast cardiac assessment also. We do have an option of even going down to the 1/4 beat cycle. It's not intended for coronary imaging, and it could be used for some of your non-contrast cardiac assessments. And finally, we have a minimum beat cycle selection, which is not meant for coronary imaging, a single rotation acquisition for your half scan temporal resolution, like your aortic imaging and such. We did look into the dose aspect also of this, and this table, although it's a little blurry, but I'll try to explain briefly over here, is on your left side, you have a reference case use, which is in this case, like, you have variability of 3 beats per minute. You have a widened SSF on, 140 millimeter scan range, 100 kV, and a large scan field of view. And that column actually shows you a low heart rate, and an intermediate heart rate, and a high heart rate. And intermediate is defined anywhere from 71 to 85. And on the right side, as you keep going on the table, is basically you have a cardiac axial dose, cardiac helical dose, and finally the EKG-less cardiac doses. So in summary, you can have a 1-beat EKG-less cardiac, almost equivalent to a 1-beat single peak cardiac axial scan, and it's substantially lower than the cardiac helical scan. Moving on to dose recommendation, those of you who are really interested to optimize your dose. So the first thing I'd like to start off with basically saying is, keep your collimation to what is needed. Most of the adults can be scanned in 140, but if you're using 160, I would stick to that. So in addition to any of your KVPs, MAs, collimation, you can also trim your full cycle phase to a shorter duration if you know your patient has a stable low heart rate. In this case, like if you have less than 55 beats per minute, you can use a half beat acquisition. You could also use 3/4 beat if you have an intermediate heart rate less than 80. And 1/4 period can be utilized along with the snapshot freeze-to technology for general cardiac assessment. And minimum beat single rotation can be utilized for your half scan temporal resolution. Now, this is basically how we did a study with University of Chicago and GE's help on this scanner. I want to first of all thank my team from UW, PI Dr. Hamid Chalian, and from University of Washington, PI Dr. Landeras, to actually finish this study. This was sort of a pilot phase to get the technology tested. The inclusion criteria was basically adult patient, anyone who is scheduled for a clinically indicated contrast-enhanced cardiac CT. On the exclusion side, standard, which was basically any pregnant lactating women not included, anyone who's previously enrolled, any allergies and such. We were able to enroll around 43 patients on this study, and the average heart rate for these patients were around 66, with a standard deviation of plus or minus 10, range around 49 to 85. So pretty stable heart rate in the patient population pool over here. And we did acquire the full period of the heart cycle to begin with, and it did multiple recons with 3/4, half, and 1/4 periods also. We did use the smart phase and snapshot freeze too whenever needed to make sure you don't have motion artifacts in your image quality. So as I said, so basically, on the left side of that EKG lead, you see is the actual EKG signal, which we don't have. We basically simulated an EKG signal from your heart rate. We acquired the full data, and then finally we did recon 3/4, half, 1/4 data periods of the entire acquisition. So the image, and we did a very thorough image quality. We had 3 cardiac readers at level 3 of cardiac imaging. We went through all these recons and made sure we assessed for image noise, subjective image quality, and all the other factors. So the key thing which stood out from this evaluation was, since we were looking for any of those, the motion corrections and all, motion artifacts. So if you look at the scale, 1 was basically completely unreadable scan, a lot of motion. 5, on the other hand, is pristine. Most of the time we fall somewhere around between minor motion, which was 4. Still diagnostic acceptable. 3, which is basically motion artifacts, were apparent, but still interpretable scan. And 2 is basically significant motion. We can't use this much. And so if you see the results from this study, so the graph over here basically shows on your left side is all the phase data. The second one is the 3/4 of the phase data, and half of the phase data, and finally the 1/4 of the phase data. And the colored bar basically shows different heart rates. So we had an average of all heart rates and less than 60, and then 61 to 70, and 71, more than 71. And you can see the image quality kind of follows that trend. When you have a higher heart rate, the image quality is falling off a little bit. But the fact is that, most of these scans were between 4 and 5. That is basically saying that there were minor artifacts in few, but it was still acceptable. So we were able to get the diagnostic image quality in these patients with the EKG-less cardiac CT in our first phase of evaluation. Here are a few examples from the study, and this is a case where a patient came with acute chest pain, and we acquired with the EKG-less cardiac study. We did use a 160 mm collimation for this patient, a rotation time of 0.23. We did use the DLIR, the deep learning algorithm, 100 kV, and we were able to scan this patient with 5 millisievert. You can see pristine image quality. There is very low cardiac noise in any of your chambers. You can see the vessels very well. Here's another example of a TAVR planning protocol. This was acquired with a patient with an estimated heart rate of 75. We were able to get the scan done in 4.7 millisievert. Again, great acceptable image quality, and you can look at all your vessels, RCA, LAD, LCX. And in this case, we even able to get all the aortic valve sinus measurement, which is crucial for your planning and follow-up for TAVR. Post-stenting, you're always worried about if you have high dense materials, how are the artifacts around the stents. In this case, you can see we acquired this as 120 kV with a CTDI of 12, dose of 2.9 millisievert. We can clearly see the stents, the lumen in the stents, and I don't see much noise or image. There are few tiny streak artifacts over here, but still acceptable image quality for diagnostic around the post-stent patient. Here's an example of a patient with a high heart rate of 75 beats per minute. This we were able to do in 5 millisievert scan. And you can see, again, great image quality, low noise. You're able to see some artifacts, but you're still able to see your vessels. Oops, I think I clicked on the next slide. Well, this is even better. This is 110 beats per minute. And this scan was done in 2 millisievert. And so again, acceptable image quality, low noise, a great contrast to noise ratio in this case, and you're able to delineate all your coronary vessels. Here's an example of a tortuous coronary arteries scanned with EKG-less cardiac CT. You do have 75 beats per minute as your heart rate. This scan was a little bit on the higher dose side, but we wanted to make sure we don't compromise any of your diagnostic image quality in this. And here's an example of a multiphase cardiomyopathy rule-out coronary artery disease case. Again, consistent, we have 160 detector collimation. Rotation time was 0.28 in this case. We have a deep learning algorithm installed. We have 100 kV acquisition and a dose of 6.6 millisievert. And you can appreciate the diagnostic image quality with the EKG-less cardiac CT. So the question I'm getting for the past few days and a week is, are we replacing EKG-triggered cardiac CT? So right now the answer is no. We just rolled out a pilot study, and it's a bonus cardiac scan for you to use in addition to your routine cardiac axial, cardiac helical scan. And I like to take baby steps in any new technology every time I try to new protocol. So basically, this is a great technology for you to look into any of your challenging patients where you may have struggling, getting your EKG signal in a busy ED setting. So that's something where you can use this currently. Or any of your TAVR planning or follow-up of your TAVR or your aorta imaging protocols. So another question I get typically asked around is, what's the accuracy of this simulation? I would say it's fairly sufficient, the accuracy, and I'll give you examples around why I say that. And even if you have a little bit off, you can use your tighter acquisition window for, if you're using one of those, then you have to be a little bit more accurate. But I don't have the exact number, but let me give you examples of, let's say your patient's actual heart rate is 60, and you're using that 100 millisecond heart cycle phase range, right? But you estimated 75. That's essentially you're using your 800 millisecond period. So you effectively acquired 3/4 of the heart cycle. And that's what our study showed, that image quality is perfectly fine when you're using a 3/4 of your heart acquisition. You have a little bit less dose, but you have enough margin to acquire that data. On the other hand, the other extreme is like, your actual heart rate was 75 and your acquisition window was 800 milliseconds, but you estimated 60. Right? This is a situation where you might be able to, you're acquiring 1/4 more of your heart cycle. And you could have done it at a little bit less dose, but the first phase is that we wanted to make sure we don't compromise any of your image quality. So that's why we kept on the safe side. And other question is, what happens in arrhythmias? So the current strategy is basically twofold. And at the scan time, you basically widen your acquisition window. You utilize your millisecond base phase prescription. And post-scan, you can use all your phase data. You do any of your retro EKG trace editing tools or motion correction. So with the EKG-less cardiac, you're already utilizing that. You're using a millisecond base prescription. You have your smart phase on to check for your least motion phase. And you have your SSF to do any of your motion correction. So for calcium scoring, we are not recommending. So since this was not the primary focus for our study for EKG-less cardiac CT, and we still recommend that you use your standard EKG-triggered cardiac axial scans. However, if you want to use a calcium burden scan from a non-contrast scan, and if you're using a larger cardiac exam where you have another contrast scan done, you could consider using 1/4 of your EKG-less cardiac scan with the multi-phase recons. So there are a few ways you can get creative around it, but initially we are basically rolling out as a routine scans. So the first phase of study, which I have been involved, was basically doing around the diagnostic image quality. We've done 43 cases at 2 different academic sites. And we are looking into future to roll into more operational kind of studies where we can have thousands of patients and show the value of cardiac CT with the EKG-less technology. With that, I want to end here and give you enough time to ask me all the questions. I would like to make this more interactive. And I'm around if you need to ask any of the questions in private about your dose or operations or any of those things. Thank you so much.
Thank you for your presentation. Can you reconstruct in 1024 high definition or no?
I believe so, yes, but I'll have to double check on that. Anyone from the GE team can please correct me if I'm not accurate.
Yeah, 1024 is independent of this feature.
I see. It's possible in future generations probably, but right now I don't think so it's possible. Yeah, please.
My major excitement for this is for left atrial appendage thrombus detection in the setting of an acute stroke code during CT carotid. angiography. Is it possible to combine this with the carotid stroke code CT angio head and neck?
Is it possible? Yes, but I have not explored into that. I think the main goal is you want to make sure your motion correction is first figure out how bad is your motion artifacts over there. And since we are right now just evaluating the cardiac, I'm not sure whether we open up your acquisition to other body parts, how that's going to affect. It's possible because essentially if you look at it, what we're trying to say is that the EKG signal is simulated. So the way we were getting earlier, the signals were from the actual leads, but now we're only getting it from a simulated signal. And you can actually take that technology to any other part of the scanning. But technically possible, but I don't think right now I have the answer whether it's doable now.
Yeah, there was actually a study from Jena University, a feasibility study, like 3 years ago that they published on the Big Five protocol, stroke workup that also included detection of cardiac thrombi. And they did the cardiac scan and the LAA and delayed or venous phase. And yeah, I mean, we kind of, we'll actually even talk about this briefly in the novel technology section here today, but we see that as a logical extension of where we're going with this.
Yeah,
So
I think that's what
very,
my
very
experience.
insightful question.
Yeah, that's what my experience has been with most of the technologies is. Like I remember dual energy CT or iterative recons, the first phase is you want to be cautious and you slowly take those baby steps and expand the technology to other applications. So, and part of my experience, majority was at MGH, and I just recently moved to UW like a few months ago, and I want to make sure like anything clinically we are using at UW and I'm consistent with that.
Can I add? I just request you to go and have a look at question number 752 in the exhibit. So we have done a similar study where we are doing ECG angios for stroke code and included cardiac screening along with the CTA to look for embolic sources in the heart. So what we have done around 60 patients in the study, and what we have done is that we do a non-gated CT angio of the neck and the cerebral vessels and follow it up with a gated acquisition of the heart in the venous phase. In the sense, after you complete the angio, you go back to the heart and do a gated acquisition of the heart. So that's what we have done, and we have got good results that we have been able to pick up more sources of emboli in the heart compared to the typical cardiac.
Yeah, I think that's where the gated simulation could be used once you have the gated acquisition.
Thank you for the nice presentation. I have a very quick question. Have you tried CTFFR with any of these studies so far?
No,
No? Okay.
but it's an interesting thought.
Yes.
I think the more we generate data around, first of all, the validation of the simulation. Because the typical question I get is, how accurate is the EKG data right now? Based on that, I think once we do a little bit wider studies, we're doing a few operational studies, we'll have thousands of patient data, get the accuracy of the EKG signal, and then we can slice it and dice it according to different protocols and different technologies.
All right. Thank you.
Irregular heart rate, you said it is possible to do it? Or not?
Yeah, it's possible to do it with a regular heart rate. The more challenging thing for your operational workflow over there is, how do you actually estimate your heart rate? Because you're manually putting it in there. So first you'll have to be confident around, am I actually capturing my heart rate correct? And second is, who at your workflow would be doing that? Are they comfortable with this thing? So I think the more we, do a few more studies around the accuracy of the simulation, then it makes sense. Like, we don't have to do any of that. So to your question, regular heart rate, yeah, definitely. And we are even doing it for arrhythmias and such, so we have variable heart rates.
And rotation time 0.28 is okay.
Right, so both 2.23 or 0.28, whatever you're currently using, they're okay with this technology. And I would urge you to talk to one of the GE teams over here to make sure, we have the hardwares and the softwares aligned to do that.
Yeah, I think the only piece on like arrhythmia management that the system, the 16 centimeter system has technology that if it sees a bad beat, it will pause. It will not start the scan. It'll wait for a compensatory beat till the heart rate stabilizes and then do an acquisition. That functionality does not exist when you do the ECG list because obviously it's not seeing a real trace. So you kind of lose that additional benefit, but there's nothing that stops it from doing the scan even during a regular heart rate.
And the technology today does require 0.23 second rotation speed as KP. Obviously, there's investigation must have 0.23 today to take advantage of it.
Yeah, that was my understanding. You have to have some of the hardware and some of your software features. So make sure you have those 160 mm detector, 0.2 and 0.28 second rotation also works. And finally, you make sure you have your software interface, because we're still working on the rolling out of how do we actually give all these features. Because I think it's early on. The first pilot study was promising, basically showing that your diagnostic image quality was not compromised in patients. And once we generate around the operational side of it, then we can maybe roll it onto other scanner models in interface.
3 is better than 2.8. I mean, it works with 0.28 too, or?
It's definitely 0.23 is better than 0.28, but right now the scanner gives the option of both 0.23 and 0.28. So if you have 0.28, you'll still be able to simulate your EKG data with this. But, yeah. But before you go and turn it on, I would urge you to make sure that one of the teams check on that. Yeah.
Question over there?
Yes, please.
Yeah, it's just a comment. I think that when you get a study with it, I'm just going to talk about function right now. When you get a study with function, I think if it's normal, it's fine, it's normal. The issue is you could get some false sense that someone has LV dysfunction or valvular abnormalities if you don't cover enough of the cycle data. So, in other words, or if you scan on PVC, or if you scan on AFib on a short RR cycle length, or you just don't have enough cycle data. So, I think it works if it's normal, but if it looks like you have a cardiomyopathy or something, it could be incorrect. And then the recommendation would be, if the suggestion was there that you need an echocardiogram or something. So I just think people need to be careful about functional information using this technique. It's just a comment.
Yeah, no, you're absolutely right with that comment. So that's why we were careful to begin with. We started off with the full range, one data entire. We cautiously went to the 3/4 data just to check the image quality and such. And again, if you're looking for those optimization option, you can go to half, but you're absolutely right to begin with and get the whole full phase data, and then you do your recons from there.
Right.
When you say half cycle or 3/4 cycle, it's average, right? Like the
Yes.
machine is taking enough out, you don't know whether it's a stroke or not a stroke.
Yes, yeah. So I mean, before all the smart phase and everything, you used to do it manually. Now with this, you're letting your scanner choose that. But again, as the comment was, you want to make sure you cautiously go towards that acquisitions or recons. So to begin with, right now the technology has given you option of all those in your drop-down menu. So make sure you select all your full phase data so that you don't miss any of your motion correction.
In fact, it knows it's doing one full phase based on the estimated heart rate level. That's
Right.
how long it's scanned,
Right.
right? Secondly, when you said measure the heart rate, estimated heart rate measure using oximeter, you want it during the scan or it can be before or after?
It should be before and during. So essentially, that's why we want to make sure, like the first study, like how accurate are we actually measuring or estimating. I was careful using the word estimation because this is essentially based on. But these are FDA-approved devices for your heart rate, like pulse oximeter and even BP cuffs. So in the end, even if you are fairly close to the heart rate, so I think the example which I was showing, 60 versus 75, and that's why we wanted to recon the 3/4 data set and see that does the image quality difference. But as long as you're in that range of not double digit variability.
Hey, so Rob, maybe one question for me here. You spoke about kind of the maybe initial use of this being around some, like a troubleshooting tool
Yeah.
for some difficult situations. As you kind of move into phase 2 of maybe expanding this in the clinical routine, where do you kind of see maybe some of the lowest hanging fruit of expanding this, the patient population that you would use this with?
Yeah, I think the first thing you definitely look around from an ED and trauma setup patients where you can easily roll this out technology. Again, validation needs to be done around the time frame of it. But I clearly see that it's going to be used as a routine clinical cardiac CT exams few years down the line. But first, baby steps, first thing is you validate those studies and then move from there.
Terrific. Any further questions for Saurabh?
Just an extension of that question. So, how do you see maybe 1/4 scan, which will truly be a non-gated cardiac acquisition? In the sense, don't worry about the heart rate, the acquisition is so fast that you don't worry about gating it. So this is an ECG test cardiac. What do you think is the future for non-gated cardiac altogether? You don't worry about the cardiac, your acquisition is so fast that you overcome cardiac motion and then get coronaries.
And I like your thought process. I don't know right now where the future would be. Again, it all depends upon the mix of hardware, software development, and finally, how do we actually use those technologies in our clinical workflow? The biggest challenge which we were seeing was, and the talk was around like operational efficiency. When I talk to my cardiac team, they say like it's the 20-minute windows. Can we cut down all these steps to increase more scan volume and such? But I think you have to be carefully treading into like different applications. As the comment was very well said, the left ventricle motion. So it's a technology to begin with to start thinking about like, can I use this data for EKG simulated applications? And then once you validate that in your workflow, let's say, your team is accurately able to put in a heart rate and you don't see major variabilities in your heart rate from and I don't have the answer of what's the ground standard right now. Can we call pulse oximeter as a sort of a moving forward future as a ground standard of your heart rate? Well, once you have those validated, you essentially are opening up all these applications which you can clearly rely on, saying that my EKG signal data is right there. And the way you get creative around it can be endless possibilities.
All right. Saurabh, thank you for an exciting presentation. Amazing initial results with this new technology. Appreciate your time. Thank you very much. Thanks everyone for attending.
Thank you all. Thank you.